Good morning, everyone. I'm Kimberly Chalia with PHCA. Thanks so much for joining us for today's webinar. A few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for one continuing education credit for all PHCA members in attendance. For those who provided an AB number, credits will be uploaded within the next 2 to 3 weeks. As we begin today, all attendees should be in listen-only mode. Please feel free to submit your questions via the chat icon at the bottom of your screen, and we'll make sure to answer those questions at the end of today's session. I'll now turn it over to Jennifer.
Well, good morning, and thank you, Kim. I appreciate everybody joining us today. My name is Jennifer Dunlap. I work with Lewis Litigation Support and Clinical Consulting in Butler, Pennsylvania. And today we're going to focus on the Geriatric Behaviors Part 2, Techniques for Intervention. This is a 3-part series, so the next part will be on helping staff cope. Just our disclaimer and our objectives. So the initially thing we want to do with behaviors is determine if the behaviors are medical, physical, functional, psychological, emotional, social, or environmental. And there's different ways to go about this in all different aspects. But if it's medical or physical, we need to have the physician involved. This could be pain related. This could be a new disease process. This could be an infectious process. And then functional, we need to get our therapy involved. Psychological or social services, activities, get all of those people involved. So we need a true interdisciplinary approach with those physicians or practitioners, psychiatry, therapy, activities, nursing, and really all people within the community. So other residents, caregivers, volunteers, visitors, family, friends, responsible parties, because those are all people part of our environment. And sometimes our environment causes behaviors. Do not jump automatically to using medications. I know that as a nurse, sometimes that is the easiest thing. When you're having problems with somebody, you call the physician and ask for that Ativan or Xanax or Seroquel, something to help us, because we don't really have time to deal with those behaviors at the moment. But we can't do that. We know that CMS has gotten more involved when it comes to psychosocial antipsychotic medications, those diagnoses of schizophrenia. But those medications can aggravate existing behaviors. It can make them worse. It can create new behaviors, or it can cause safety concerns, especially falls, increased confusion, decreased intake because of lethargy. So we really don't want to just start with medications. There are some considerations we need to look at. And I did my master's thesis on geriatric behaviors, and I can tell you I learned a lot through that. When you have somebody with hygiene, is it because they have a loss of smell? I never thought of that before. They don't think they stink, so they don't need a shower. But we can smell that urine smell or BO or whatever. They have that change in body temperature. So just getting them unclothed and taken into the shower is causing them to be even colder. They don't want to do that. Your fear of falling or your vulnerability, being naked in front of another person, especially a caregiver of the opposite sex. Insomnia, they just may not be tired. Or they have a fear of falling or being in the dark, being alone and dying. I've had some residents that say, I don't want to go to sleep because I'll never wake up. If they are repetitive, it could be because they're hard of hearing. Do we have audiology involved? Do they have a wax buildup? Do they need hearing aids? Or maybe they just don't remember. So some interventions regarding hearing is promoting a quiet environment for those who prefer quiet, playing a CD with nature sounds or white noise, asking individuals their music preference. We will go through the 5 senses and various interventions for those 5 senses and maybe why we have some behaviors. This is not all inclusive. My ultimate goal for today is to kind of get you to think outside the box and really make other considerations as to why these behaviors are being exhibited. I know for me, I used to have residents who really enjoyed 50s Big Bang music. That made them happy. So during meal times in the dining room, we would ask everyone if it was okay to play some 50s Big Bang music. Their intake increased because they were happy and they wanted to listen to the music, maybe stay a little longer, not just refuse and then leave. They would actually start to eat. Touch. Textured objects such as specific blankets or clothes. We don't think of this for the elderly, but if you do think of young children, sometimes they have that security item with them, and that's because there's a texture to it that comforts them. Getting them involved with activities such as folding clothes or sorting buttons or bolts in a container, rolling yarn into a ball. It's just keeping them busy. And it's just giving them that textile stimulation that they're looking for. A weighted blanket or vest. When I am most comfortable is when I have my Sharpa blanket with me. It just makes me feel like I'm floating in a cloud. It makes me feel better. Dolls. I know there's some contention over dolls. You don't want them to be kind of looked at as an infant, but there are dolls that just make people feel better. I had a husband and wife in our behavioral care unit, and this lady took this baby doll with her everywhere, and her husband thought it was their child, their infant. They would work together. When one decided to go to dinner, the other one would watch the kid. It would keep them entertained. And they do have real life looking babies and animals. As my aunt was getting more and more with her dementia, I got her one of those real life dogs. And she would just entertain herself and take the dog around and show it to her other peers within the facility. And going back to old school nursing, that massage and therapeutic touch. I know part of my nursing curriculum really dealt with the therapeutic touch. You have somebody that doesn't feel well or somebody that has a lot of stress in them. Just taking those few minutes to get some cream and rub on their back or their hands makes them feel better and decreases behaviors. Taste. Can we give them some comfort foods? And those comfort foods relate to where you grew up. As I said, I had an aunt that was in the nursing home and she was from the South. So she liked her fried chicken and she liked her Coca-Cola. Well, if that's what made her comfortable, that's what she got. And she quieted down. She wasn't hollering as much and she wasn't going around causing chaos. That warm milk or tea, for younger people, that may not make sense, but we were always told if you couldn't sleep, try some warm milk. Ice chips. If they're able to kind of crunch on soft ice chips, that also gives them some comfort. Smells, aromatherapy, battery-powered candles, foods. Certain foods have that smell. Sometimes when you have activities baking with the residents, it is really helpful because they have those fresh aromas throughout the building and it makes them feel like home. Fresh flowers. I do want to strongly urge not to utilize perfumes or strong smells. And we will actually discuss that in the next series with staff, because those perfumes or strong smells can cause irritations, allergies. It may make somebody flash on somebody that they didn't like previously, and that smell reminds them of that person. So we really want to try and stay away from that. I can tell you, I've been in the hospital and I've had nurses come in that just spray themselves with their perfume. And I'm like, whoa, I can't even get them near me. For somebody that's an asthmatic, I can't stand those smells. Sight. Soothing pastel colors are usually pretty helpful, and we need to consider that within our building itself. If you have your inside paint colors as those drab colors. It makes them feel drab. Soft lighting or non-visual for the non-visually impaired people, or bright lighting for the visually impaired. Visual wayfinding cues, such as a scarf on the doorknob or a picture of a loved one on their door or bed frame, or the resident's picture on the door. You know, if you're lost and can't remember where your room is, having those cues, those visual cues really help you to decrease the anxiety. I want to discuss the schnozzling room. These are soothing environments. They have stimulation for sight, touch, smell, sound. They have adequate lighting, multiple tactile experiences, soft music, aromatherapy, beanbag chairs, a textured floor. I know this seems kind of out of the box, and it really does seem like it's something that we can't do. But I do want to tell you that I have a building that I go to on a regular basis, and they have one. They have one actually for their staff. So when staff are able to take a break and they just need that time away from the environment of their workplace, they can go into the schnozzling room, and it kind of calms them and rejuvenates them for the next part of their shift. But they also use it for their residents. If you have a resident who is just really having a hard time, sometimes taking them into this room helps to calm them, which decreases behaviors. Some additional interventions, pain management. We know that can be a big one. I had a lady that's, she was just always trying to hit you and kick you and everything else. And it was her contractures that were causing her so much pain that she didn't want you to touch her. So how can we help her with pain management? Whether that's medications, whether that's hot and cold, or therapy getting involved. Pet therapy, that's a big one. And I know we try to really get pets involved, and it can be a struggle. We can have issues with infection control. We can have issues with who's going to take care of these pets. But it really does help residents to have that pet therapy every so often. Arts and crafts, going outdoors, not feeling like you're imprisoned, getting that fresh air, poetry, photography, gardening, and various relaxation techniques. Just wanted to include this information. There are various aromatherapies that can be stimulants, sedatives, and I just wanted to kind of give you a list of all of that. If you have somebody that's very hyper, you don't want a stimulant in your aromatherapy. So this is just kind of an FYI. Other strategies to consider: toileting schedules, communicating face-to-face and at eye level. You have a resident that is constantly in their wheelchair, and people are standing and running around talking to them, and you're looking down at them. That makes you feel intimidated. So get down on that eye level and talk to them face to face. Make them feel like they are a part of something, a part of that relationship. Offer cueing. If you can tell Miss Jones, do you see that red scarf on that doorknob down there? That's your room. Those are ways to kind of help them having less anxiety. Using a calm demeanor. This is important. I know staff are in the hustle and bustle every day of what they're trying to do, always thinking of the next thing that needs done. What other tasks need done? And this person is now having an issue where I have to go there when it wasn't part of my routine. But using a calm demeanor is so important. If you come up to somebody and have a panicked look on your face, they're going to internalize that. And forgive me, but resting bitch face is something that I have. I have to be conscious that when I'm thinking of other things, I have that look on my face like I'm angry. It is not how I want to be perceived, but that is how people see me. And avoid debates. If Miss Jones tells you that her husband is looking for her, don't start saying, no, he's not. He's dead. You don't need to worry about your husband. Don't debate the resident. Listen to them. So be tactful, but honest. Compliment somebody on their appearance. You know, Miss Jones just got her shower and put on fresh clothes. You know, Miss Jones, you look really good today. That's a nice color on you. Just the fact that you said that to them, you are thinking of that person, makes them feel better. And they just paid me a compliment. So maybe I should wear blue all the time. Offer for the resident to choose outfits or activities. Don't just go into somebody's closet, pick something out, and put it on them. You know what? If they're not communicative, they may not like that outfit. They may think it's tacky or it doesn't match, and that can cause behaviors. Plan on more daytime activity. Why is that important? Because then they'll sleep at night. We want to try and get their circadian rhythm to where it fits best. So if we get them more active during the day, hopefully by the evening they start to calm and then they sleep at night. Various relaxation exercises, that's where you can get your therapy involved, including restorative. Night lights. You know, sometimes it's just that fear of the dark, or I wake up and I have no clue where I am. If I had that night light, it would kind of help reorient me. Listen, be reassuring, be understanding, and again, don't argue with them. Distractions are a huge issue. You know, if you're in the middle of a med pass and somebody comes up and starts talking to you, you know that's a distraction. You can make an error. Well, you have a resident that knows what they need to do, but then there's so many other things going around them that they can't focus. That's a distraction causing anxiety. Focus on positive behaviors. If you had a nice conversation with Mr. Smith today, you know, he was being very polite, he was courteous. When you're done, say, you know what, Mr. Smith, I really enjoyed our conversation today. You're having a good day. Focus on those positive behaviors. Set boundaries, but in a positive way. Respond to any positive behaviors, but ignore to the extent possible bad behaviors. If Mr. Smith starts cursing at you or making sexual comments towards you, say, Mr. Smith, I see that we had a good conversation up until this point. I'm walking away. Body positioning. This is huge. There is a thing for crisis prevention interventions, and in hospital settings, it's mandatory for us to take, but you learn about how your body positioning, that nonverbal communication can really cause issues. If you're standing in the doorway and they feel like they don't have a way out because you're blocking it, that can cause issues for that resident, just becoming claustrophobic, feeling intimidated or threatened, and then they exhibit behaviors. Same with crossing your arms. And I know I have a hard time with that myself, but if I'm standing talking to somebody, I have a habit of crossing my arms. That to them means that you're closed off. So I try to put my hands behind my back and I'm more open. We don't really pay attention to our nonverbal communication techniques, but it is huge. You have somebody from a different generation that you're working with. You have somebody that's had different events happen in their life. And sometimes our nonverbal communication is what causes those behaviors. Include family and friends. There are several times where I've had issues with a resident and I will contact their family, their loved one. Hey, can you talk to your mom here and see if you can kind of calm her down? Or if you can come in, that would even be better. But we also know sometimes family can be triggers. So this is where communication within the team becomes important. My aunt was one of those ones where she did not get along with her daughter at all. That's why I became her power of attorney. So I knew that when she was having issues, they needed to call me, not her daughter. when you would bring things up to her to talk to her, I would have a note that said, don't bring up her daughter P, because that will cause her to have behaviors. Allow them to sit or walk with you. I also had a lady who, she just felt very isolated in her room, but was an introvert and didn't like to be around other people. When I was at my desk, she would just come in and sit there with me and just kind of look around. Never bothered me, just sat there. Occasionally I'd look over and I'd say, "Hey, Sophie, how are you doing today?" And she would answer and then just continue to sit there. Having them walk with you. You have those people that continue to wander. Well, as I'm going up and down the hall doing this or that, having them just walk with me. One of the big things too is avoiding news on television. And I just want to explain that a little bit, because we know what our realities are. We know what our society is like. We know that there are bad things that happen within our country. You have somebody who has dementia and they think it's 1972 and they're trying to figure out what is all this stuff going on the news. That shouldn't be happening. Or you have somebody that is just a worrier and you see all of these bad things going on in the country. That will increase behaviors. When I had a facility that had their dementia unit, I had them block all the news stations from their television, because that really causes increased confusion, increased worry, increased anxiety, a desire to want to leave and either go help others or just get away from the situation. So sometimes those news stations, I know myself, there are days I just avoid news totally because it increases my anxiety. So why do we want to do that to our residents? If a resident resists care, there's always a reason to that. So can we utilize devices to help with comfort? Can we offer them some fresh water? They don't want to drink or eat for us. So can we provide favorite items for them? Or, maybe their water pitcher just is stale to them and it's not cold enough. Continuity of care is important because we are able to know our residents. And I know that is not always feasible. We utilize agency. Sometimes the staff get burnt out, and that is fine. But to the best of our ability, how can we have continuity of care? My 24-hour sheets were very inclusive for my CNAs, and it had a lot of likes, dislikes, how they want to be called. When people call me Jennifer, that's when I was in trouble. I prefer to be called Jen. And that's just more of a relaxed thing for me. Maybe change the time of care. You have residents that like to be up at 4 or 5 o'clock in the morning and get up and get their day started. Well, if you wake me up at 4 o'clock to give me my shower and get my day started, yeah, I'm going to give behaviors back. So let's try and incorporate their own pastimes. Place them in bed when they're fatigued. It's just like you have infants that cry when they're tired. Residents will exhibit behaviors when they're tired. Can we put them down for a nap? Can we put them to bed earlier and reposition them frequently? That helps with skin breakdown, but that also helps with pain management. That's why we flip-flop in bed. Our body gets used to one way. Well, that's just not working anymore. So we reposition ourselves. Help the residents reposition themselves. Activities. I really believe that activity departments should be included in the evenings and weekends. If you can't, can you have stations where residents can go do things? Again, when I had a dementia unit, we implemented an activity station. It had coloring books, adult coloring books, crossword or puzzle books, Legos, building blocks, Lincoln logs, just to be able to have them be able to do something. Puzzles, My great grandmother in her 90s, she would just sit there and put puzzles together for hours on end. That was what she liked to do. So do we have some puzzles in an area with cardboard or something for them to be able to sit? Photo albums. Um, Even having them make photo albums. If they have some pictures of their loved ones, can we get them a photo album and allow them to put the photos together? Again, my great grandmother was one of those ones where every photo had to be put into a photo album. And she just loved to sit there and do that. Not only just look at the pictures as she's putting them in, but then later just going back through the photo albums and remembering things throughout her life. A positivity poster is something that I used with my aunt when she was in the nursing home. This was posted in her room and it gave a quick review of things that she liked to discuss. So she had her dog Jingles. She was born in Mississippi. She loved to crochet. She had her daughter Lori that she loved, and her grandson Jonathan. Her niece, she always called me Jenny. Her sister Della, she loved. She loved hyacinths and various bushes and plants. Her favorite time of the year was the 4th of July barbecue. She was born in September, so she had a September birth date. Her favorite song was A Bushel and a Peck and A Hug Around the Neck. She loved Johnny Cash, the movie Steel Magnolias. And just a funny little thing that she always did was this little jingle, beans, beans, a magical fruit. And I would post the lyrics there, and you just said something off of this board to her and it would change her memory to something positive, and then she would start to discuss it. And again, it was on blue because her favorite color was blue. So if she was having a bad day, I would say, pick out an outfit that had blue in it. That's her favorite color. It made her happy. So this is just something that I had considered, and, again, made this up, laminated it, put it in her room, and it was a quick reference for the staff. This is helpful for staff that don't get to see the same residents every day, whether that's agency or, um, you know, somebody coming in extra working a different unit. It's a quick reference. Another one is a memory box, whether that is a box that somebody can open, as you can see in this picture here with great thoughts, and it just allows them to go back into their positive memories. It could also be a shadow box that is displayed in their room. I have seen some facilities where it's on the outside of the room, and they allow the residents to put positive things in there to remind them this is their room, but they also look at it and see positivity. Again, these are things that I'm just trying to get you to think outside of the box, things that activities could be involved with, therapy could be involved with. If they're on speech therapy and you're working on some cognition, they can also gather information for these things. But again, it's an interdisciplinary thing. Talk about it at care conference with the family. What are some positive things in mom's life that we could bring up to her again to kind of help with these behaviors? Various validation techniques. So agree with what a person is feeling at that time. That helps us to be validated. One thing that we've always learned is a feeling is a feeling and it needs to be validated. We are allowed to feel the things we are feeling at the moment. So validate that. Don't say, oh, you have nothing to be upset about today. Everything's been going good. What's the sense of talking to somebody like that? Allow them to have those feelings. Avoid arguing about content, as we discussed earlier. You don't need to tell them that their mom passed away. What is that doing to them besides making them more upset? Avoid interruptions with your facts or corrections. Again, she's looking for her mother. You don't need to interrupt her and say, your mom died. Do you know that you're 90 years old? How is it possible that your mother would still be with us today? We don't need to do that. We will look at that more in depth in the third part of the series. But these are things that I wanted you to be aware to kind of discuss with your staff as well. And show the person you're listening. So if they're talking about, getting to their car so they can leave, oh, what kind of car do you have? That starts to make them feel like they're important and somebody's actually listening to them. As somebody who worked as the 3 to 11 supervisor for a number of years, sundowning is one of those things where we just despise it. Very hard to handle. It is difficult to get the residents not to exhibit these behaviors. And again, we don't want to just give them medication. It's hard for the staff to get done what they need to get done. And it just interrupts a lot of things that happen in the evening. So encourage short naps throughout the day. Sometimes sundowning is because of increased fatigue. Have good lighting until bedtime. I always made it that on my 3 to 11 shift, by 10 o'clock every night, those hall lights were out. We had a more quiet environment. Limit visitors and noise in the afternoon and evening. The more that we pump somebody up with evening visitation, the longer that they stay up, the more the behaviors occur. If we have to have visitors, and again, visiting needs to be available. If those visitors want to come in because they work during the day, we want more of a quiet atmosphere. What can you do with that person to quiet them? Maybe walk them through the halls, get them to talk about various things. Attempt diversion, such as those distraction techniques we just discussed. No arguing, attempting to change behaviors, attempting to redirect. We can do that to the best of our ability. Exercise. One thing that my 3 to 11 shift did every night, after dinner, those people that we had issues with sundowners or increased behaviors, we put them in the hallway near the nurse's station. And every evening at a certain time, the staff would come out, we would play certain music, and we would kind of have a little dance party with them. It made them feel good. The staff were involved. The staff were able to have a good rapport with those residents. They looked forward to that time of day. And honestly, it just kind of tired them out. They get that little bit of happiness, and then it was time for bed because they were fatigued. Limit caffeine and sugar. This is where your dietary needs to become involved. We should not have caffeinated coffee for dinner. I mean, we should not have that. It increases their time for wanting to be up, and it increases their anxiety. Maybe have an early dinner and then have light snacks before bed. For wandering, we have to allow residents to wander. And I just actually had a friend of mine send me a video about, I think it was over in Germany, but it was over in another country. They actually have a dementia village where the entire village is an area for residents to be able to wander. They started this in 2007, and it has been very successful. But it is an entire little village with shops and flowers. It's an outside area. The entire village is blocked off. It had a secured entrance. The staff actually didn't wear scrubs. They wore plain clothes, and they were always monitoring the residents. But it's an area for them to utilize that extra energy that they have. That is part of the reason people wander. They have this energy, they don't know what to do with themselves, so they walk. When you are looking at residents who are wandering, always approach them from the front. If you come from behind them or certain sides of them, you're going to startle them. And that is going to increase behaviors, that is going to increase the wandering. Allow them to wander. If they are supervised, allow them to do that walking. If that's what makes them feel comfortable, allow them to do it. We just need to make sure that they're safe. Try and provide a circular pattern. So if you could tell them, go down this way, go around this circle. That allows them to stay within a certain area, but they're able to continue to walk. Have them walk with you and talk while you walk. Just bring up some little things, how was your day? Or, tell me about your pets or something. Have that conversation with them. Hold the resident's hand or offer your arm. Sometimes if you're seeing that they're a little off balance, just saying, Miss Steele, can you want to hold my hand as we walk? And then walk them back to their room so they're on a safe area. Don't try to reorient them unless they ask. So don't keep telling them your room is down there on the right. Maybe they don't want to go to their room. They just want to walk. But if she asks you where her room is, then reorient them. Providing visual cues. Sometimes if you have each individual area be a different color, for them to know I'm on the pink zone. So they know that if they stay within that pink area, then they're in the right place. Sometimes that really helps. Placing various things along the wall with arrows or various pictures. If I like dogs, maybe if you have all of your pictures throughout a certain wing have dogs on them, then I know that that's my area. And this can all be done tactfully. This can all be done professionally, but still have that area where residents feel more at ease. Managing aggression. The number one thing I've always done with aggressive residents is distract them. How can I kind of get them to think differently than they are at that moment? Being on a mental health unit, you would have resident on resident a lot because they're all angry and, able to antagonize each other. And I had two residents that wanted to do a fist fight, and one was picking up her walker to strike the other one. I was able to distract her right at that moment and talk about her daughter. She put her walker down and then she started more of a positive. I was able then to get another staff member to distract the other resident that was angry and talk about something she liked, and we were able to separate them. Avoid open-ended questions. This is important because if I'm having cognitive problems, as it is, and then you ask me an open-ended question, and now I'm trying to think of what I want to say to you and what those words are and try to get those words to come from my brain out my mouth, it causes anger. Keep it simple. Is it a yes/no question? Is it something I can give two various options to them and them just repeat what I said? So try to avoid those open-ended questions. I can tell you that sometimes I just have problems getting the words out. It drives my husband crazy. I know what I want to say, but then I can't get the word out. I get angry with myself. So imagine that being 24/7 for somebody. Validation therapy, again, validating how they're feeling at that time. Just remain calm. Don't get upset because, again, they will absorb that and internalize it. Speak in simple and short sentences within the line of sight. Do not be talking to somebody from in the closet. If you're in there trying to get somebody's wardrobe for the day and you start asking questions, do you want the black pants today or do you want the jeans? No, turn around, offer the two options, whether they point or whether they verbalize it to you, but don't talk away from the person. Go slow. This is huge for our aides. They are always, again, so task oriented that sometimes they're in such a rush to get things done that they speak quickly. And by the time you're done speaking quickly, the person has no clue what you said. They're not able to process those things as fast as you're going. So slow down and smile and praise. That goes a long way. Just having that smile on your face makes them smile. It is something so simple that we don't think of, but it works. How to encourage hygiene. Gather everything before starting the process. You do not want to put somebody on a shower chair, put covers over them, and have to go and get their clothes for when you're done and get the towels, get the soaps. No, have all of that together before you start. Ensure warmth. As I said, these residents are already cold. A lot of times, we have decreased fat reservoirs or we have decreased muscle. We have poor circulation as we age. We're already cold. How many times is it 90 degrees and, we're all sweating and you have people with coats on and extra blankets because they're already cold. So that's why they don't want to get in the shower. I don't want to take my clothes off. I'm already cold. I don't want to get ready for bed because I'm just now getting warm. Why do I want to take my clothes off? So try and keep them warm. Allow resident to have the input and options. Explain what you are doing. If you come in and just start ripping somebody's clothes off to get them into the shower and do this, that, and the other thing, if you're not explaining to them what you're doing, A, that can be considered abuse, and B, it increases their behaviors. They start to get fearful and then they want to fight back. A little bit of music while they are getting their shower or while you're doing the PM care. Sometimes that's just soothing enough to allow them to be calm with you. Encouraging nutrition and hydration, liberalize their diet. As my grandfather was getting sick, he was a diabetic, and my grandmother would not allow him to have what he wanted. No, he's diabetic. He had a cardiac diet. He can't have that extra salt. He was on thickened liquids for a while. No, he can't have that coffee unless it's thickened. Well, when she wasn't looking, we would give him whatever he wanted. Liberalize that diet. It gave him some happiness. Why not? Determine the home regimen for meal times. Again, sometimes how people did things at home is not the same routine that we have at the nursing home. And that's because of our scheduling conflict. It shouldn't be something that they have to deal with because it's convenient for us. Ask about their preferences. Portion sizes are huge. Sometimes those portion sizes that you put on their plate are overwhelming to them. We understand that we need to give them a certain amount of calories and, so much protein and so many vegetables. That's important too. But the portions that we're giving them are overwhelming. So maybe put them in individual bowls and allow them to eat one thing at a time, or do 6 meals for them throughout the day that are in smaller portions. The environment, is it distracting? On the 3 to 11 shift, they would always have the news on while we were in the dining room for dinner. No, we're getting rid of that because that distracts them from trying to eat their meals. Is there poor lighting? Sometimes they can't even see what's on their plate. So that's why they don't want to eat, or they don't know what it is. So just tell them what is on their plate. Talk to them while assisting. Tell them what each bite is, have a conversation, and make them feel included. I despise when employees talk to themselves, in between themselves when there is a resident sitting there. They feel like they don't exist. They feel like they're not important. Include them. You should not be talking about your own personal thing while you have a resident sitting there. This is about the resident, not about us. Are they having speech issues? Maybe some problems swallowing or coughing or their nose running as they're eating. That can all be signs of aspiration. So do we need to get speech involved? Maybe they have poor dental health. It hurts to chew and they can't tell us that. So is the dentist involved? Do they need assistive devices like a suction plate? sometimes just everything combined into one makes them more confused. Having those various sections makes it easier for them. Do they need build-up utensils? A cup with a lid, a two-handled mug. I've had residents who refuse to drink because they can't use those cups. They start to shake and they spill it everywhere. They get frustrated, they're done. So maybe we need to give them something with a lid, or, an easier way for them to swallow. And pharmacology review. Pharmacology reviews are really important, and we don't realize that. But we also need our pharmacists to be on board and look for certain things. Do they have a medication they're taking that causes a decreased taste or a decreased sense of hunger? Or maybe something that they're taking causes a metallic taste in their mouth, so they don't want to eat. That includes, pharmacy for various reviews, as far as sometimes something as simple as a stomach medicine can cause increased sexual behaviors in men. These are all things that the pharmacist should be aware of, that we want to have looked at. We have sexual disinhibition and hypersexuality. Usually disinhibition is not a problem. We would prefer that, but we do have residents with hypersexuality. Sometimes because there's a lack of privacy. If there's a lack of privacy, I don't want people to see what I'm doing, so I'm not going to change my clothes. I'm, not going to go to the bathroom with somebody watching me. But sometimes if there's a lack of privacy, it actually does the opposite. Well, if there's not going to be any privacy, then whatever. I've had residents just taking their clothes off as they're walking down the hall. They don't care. The environment is stimulating, so then it caused more of a hypersexual behavior. And again, certain medications will cause those issues. Sometimes it is a medication that you would least likely expect to cause hypersexual behaviors. We had a resident on resident that we had to report to the state. So we did a pharmacy review. And let me tell you, the gentleman was on 5 different meds that could cause hypersexual behaviors for him. We didn't expect that. Certain blood pressure medications. Again, he was on, I think it was Protonix or Prilosec, and that can cause behaviors. Maybe sometimes another resident or a caregiver reminds them of someone they once loved, so they're more attracted to that person. These are all things that we need to consider. Maybe it's separating 2 residents, or maybe it's trying to reorient that this isn't your wife, honey, this is Miss Doe. And staff cannot get upset if residents become hypersexual towards them. They need to find ways to decrease that behavior, not get upset and start acting back towards that resident. And that's something that we will, again, discuss in the 3rd session. So really looking at a summary here, aging can be viewed as a constant loss. They lost dignity. They lost friends over the years. They've lost family members. They're losing their mobility and their overall dependence. So what can we do to help them not only increase their quality of life, but that decreases behaviors? If Miss Jones is constantly sad because, she's lost some people in her life and she just misses them dearly, well, tell me about those people. Tell me about your son that passed away. Allow her to find some happy memories. Overall, these are all individualized. I'm trying to give you examples of things that have worked throughout the years and what research has kind of talked about as far as various interventions, but everything is individualized to each resident. What works with one may not work with another. Something that has been researched that works with the majority of individuals may not work with certain individuals that you have in your facility. We have to critique everything. Our goal is to look at the root cause. Why is the resident having these behaviors? That's why we discussed at the beginning, could it be Could it fall into one of these categories why they're exhibiting behaviors? We need to look at the root cause. And always remind the staff that just because somebody exhibits the same behavior every day does not mean you don't chart on it. We may be putting interventions into place that you're unaware of. We need to know if they're working or not. You know, if Miss Jones was yelling every day for a month, we implemented new interventions, and then the aides or the nurses decided, well, she does it every day, and we chart by exception, so there's no reason to chart on it. Well, no, we think our interventions are working, but it's not. And all it does is cause frustration for the staff because they continue to deal with the same behaviors every day, but they're not communicating it to us. So it's very important for communication because overall this helps quality of life. This helps our staff deal with various things, and it increases morale with the residents as well as the staff. And this is just my biography. I did not put my information on there. I missed it this time, but you can always reach out to me at jennifer.dunlap@ltclnc.com. You can reach us through the website at www.ltclnc.com, or you can contact us on the phone, 724-256-8252, and we would be happy to come and help you with in-house presentations or webinars via Zoom, or if you just have some questions or anything that we can help you with, we're always happy to help.
Thanks so much. This was a great presentation. I'm looking forward to part 3 next month. I'm taking a look and I didn't see any questions come through, which is not uncommon. As always, please be sure. Oh, I will type Jennifer's email out for you, Bill. As always, please feel free to email Jennifer or myself after today's webinar. We're happy to answer any questions after the fact. And Bill, I will send you Jennifer's email. All right. Thanks, everyone. Thanks, Jennifer.
Thank you.